everybody. Hope you got some of the gossip out anyway before you have to concentrate again. So it's a great pleasure. I'm going to introduce our second keynote speaker today, Professor Chris Nugent. Chris and his team have travelled all the way down from the north to be with us here today. And it's quite unusual actually to be introducing a professor of biomedical engineering at the sort of conferences I generally attend, but it's a great excitement. Chris and his team are doing some extremely exciting research on people, developing technologies for people with ambient assisted living. Chris is the leader of the Smart Environment Research Group up in the north, and they are involved in cutting edge technologies, stuff we can only dream of, real futuresque. And Chris and his team are looking at how to best use reminding technologies for providing the best possible quality of life for people using these technologies. So with no further ado, I'm going to hand you over to Professor Chris Nugent. Thank you very much.
Okay, thanks very much. Good morning, everybody. Can you hear me okay at the back? Usually people tell me at the end they couldn't hear me, so I'll just check at the start. Okay, so thanks very much to Jane for inviting myself to come along and talk to you today. What I'm going to talk to you about is the experience I have had over a number of years working with technology in healthcare, and has really culminated around the area of providing reminding solutions, reminding technologies. So it's quite interesting that Jane had mentioned we're sort of reaching a point, and a number of our speakers this morning reached a point where we have this need for multidisciplinary teams. And I guess I started this journey in 1999, so quite some time ago, as a naive electronic engineer or biomedical engineer. And you'll see through some of the slides that very quickly we realised that it does require a lot of input from a number of different disciplines. And it's really exciting to see a number of colleagues here from all different spectrums of research. I think that's really where we need to move to in this area. So just to give you a little bit of background, I'm from the University of Ulster in Northern Ireland. We have 6 faculties in the university. I'm from computing and engineering, and we have 4 campuses, and I'm based in the Jordanstown campus, which is just outside Belfast. And as Jane said, we did travel all the way down from the north, and there's the map. Google Maps told me it would be 3 hours, 50 minutes. I don't know what car that was based on. We did hire a car, and it was a very, very, very nice Mercedes A180, and it still took us 5 hours to come down. So if anybody knows a better way, please let us know for the way back. So you're all very welcome at any time to come and visit us in our labs in Northern Ireland. So just very quickly, I lead the Smart Environments Research Group at the university. We're a team of about 42, 43 people at the minute. That's a mix of academics, PhD students, and researchers funded from external projects. And we do have a mixed background: real electronic engineers, computer scientists, biomedical engineers, and about 3 months ago we employed our first health scientist within the group. And that's really interesting for our dynamic and computing department to have that profile of researchers. So we have a number of smart labs. As Jane said, we're interested in ambient assisted living, and we have a number of posters I'll talk about just at the end of the presentation to give you more of an overview of the work that we're involved in. So what I want to talk to you today specifically about has been the experience that we have had in the development of reminding technologies. And whenever I look back, we had our first project in the group in 1999. It was a solution that we aimed to develop to help people with their medication. And that sort of moved on into mobile solutions for people with dementia, support people with dementia. And then we moved on to supporting the carers of people with dementia, and then we've moved on to let's look at longer scale evaluations of all of these technologies. And we've sort of come back on ourselves to appreciate the need of behaviour change and the need for self-management, and how can we have more of an engagement between all of the stakeholders, the patient or the person with dementia and the caregivers themselves. So it's quite a large journey that we've had to realise that we were very naive at the outset to think that we could do this all ourselves from an engineering perspective. And what I want to do is just very, very quickly, in maybe 10 or 15 minutes, run through some of the experiences that I've had in these projects, outline what we've actually found, and then talk about some of the new work that we've been involved in the past 2 or 3 years in this area. Yeah, so I would say 60–65% of the work in our group at the minute is focused on supporting people with dementia and their caregivers. So I want to talk a little bit just about the scale of that problem. It's a huge, huge problem. And then I want to talk, as I said, about the work that we've been engaged in within this area of developing technology-based solutions. So slightly different from Liam's presentation, which was coming more from things at a clinical perspective. I want to tell you more about the technologies we've used, the technological approach that we've adopted. And then through the lessons learned and the findings, and I must be honest, we did find a lot of challenges, a lot of practical issues along the way with technology. I want to share those with you and show how that has really redefined how we've moved forward in this area. And I guess we can call a lot of our work, it does fit under the topic of mHealth. Okay, so I guess we could all talk all day about the problems associated with dementia and all of the stats. I don't want to do it. I've just one slide here to give you an idea of the actual scale of this problem. So 44.4 million people in the world are living with dementia. So a huge number of people. The World Health Organization is predicting that's going to really, really radically increase to 66 million in 2030 and 115 million by 2050. So very, very staggering figures. And there's the cost from 2010, nearly over 600 billion US dollars. So huge costs, huge numbers, huge impact on society, a huge problem obviously for those suffering with dementia and also those providing the network of care. So we looked at this problem, we looked at the unmet needs, we looked at how we could try and introduce some technology, some mobile-based solutions, and we found a very, very, I think, seminal study published by the VMC in Amsterdam, and they had conducted a survey of caregivers of people with dementia and people with dementia themselves, and looked at the areas of unmet need. And there's 4 main areas that came out across both of the cohorts. Support with memory, support with daily activities, support with communication, and provision of feelings of safety. And on both the people with dementia and the carers, the provision of memory support or aids with the issues supported with cognitive impairment came top of both of the lists. So this was the area that whenever we were sort of trying to justify or trying to underpin which sort of facet of the challenge were we going to work with, we based a lot of our work on the findings from the studies in VUMC, and we also partnered with the hospital there, which helped us in our design, and I'll come back to some of those collaborations shortly. So from a technology point of view, I think we can all appreciate their benefits to the management of the factors associated with the challenges of dementia. We know what those risk factors are and we can target those. And I think the takeaway message really for today, if there's nothing else that you remember from my presentation, we can say that mHealth is one possible solution, but it's not going to solve all of the problems. It's not going to solve all of the practical issues with people with dementia or people who require some form of technology solution in healthcare. If we find the right cohort, if we apply it in the right way to the right people, then we will have a positive impact. And I think that's the underpinning message that goes through all of the projects, all of the areas of research in our group. We can offer a good solution if we find the right people and deploy it in the right manner. So my journey, and this is what I want to, I think, I've reflected a little bit on the journey that I've had in the development of mHealth, and that's what I want to share with you today. It cuts across 3 areas. So my work as an early or as a young researcher focused quite a lot on the development of decision support systems, and that really kick-started a lot of the work that I was involved in. From an application point of view, very quickly I moved into the area of reminding technologies, and obviously to provide some evidence that this did or didn't work. I've focused a lot of my effort on evaluation in situ with what we've developed. And that's led to interesting approaches of how we can develop our solutions, how we can engage users and stakeholders in the full design process, and I guess from a technology point of view, how we can introduce new contemporary pervasive and mobile computing solutions. So if I go back and I looked at this work that we presented at a conference in 2004, and I think we picked the most complicated architecture that we could find based on temporal reasoning. We said, okay, this is really cool, and we'll build all of these rules, and that's going to be our underpinning solution for our reminding technologies. And actually, this is a fairly highly cited paper of ours, but very quickly we realised, where are these rules going to come from? Who's going to update the rules? What's going to happen if someone isn't in the environment when this reminder is set? And very quickly we had to move on and realise that complex computational approaches from a computer science perspective aren't really going to solve the problems that we're facing with the solutions that we need to deliver from an mHealth perspective. And at the same time, in another sort of track within our group, we were involved in a European project, and it was the first European project that I was involved in, and it was funded under FP5, and it was to develop an internet-based solution for medication management. And we proposed this, I guess this was 10 years ago, so it was quite innovative at the time. We proposed this architecture of involving a pharmacist and e-prescriptions, and we'd have these mobile devices to house all of the medication, and we'd have these portals where people could look and see how many types of medication were missed, and we could deliver all these types of reminders. So we produced this device as one of the main outputs of the Medicaid consortium, and we produced a sort of a suite of web-based software which allowed us to schedule and monitor the adherence that people had to their medication. So a lot of time, I would say, in that project, and that was between 2001 and 2005, a lot of time in the development of hardware-based solutions. And in FP5, that was more in line with what was being requested from the programme, or what was expected for us in terms of the deliverables of our project. And the results from this were very, very interesting. One thing, when I look back, our numbers were very small. And again, that related to the work plan that we had. So we would maybe 32 months of a 36-month project was solely development, and then we had this small evaluation phase at the end. So we found a number of interesting factors from this project that we didn't really set out at the start. We found that our solution was, or provided an educational experience for those who used it. We found that we needed to focus it on a specific cohort, that it wasn't possible to cover all of different needs of all users. And really all of the feedback was, this needs to be more mobile. We need to make this more, take it out of our house and not restrict someone to use it only within their home environment. And that was because we had to link this device with, at the time it was a high-speed 56K modem in the home environment, to give the sort of feedback for the different alarms and messages that we needed to send. So I think this was the first real insight, the first real understanding that we had of our engagement with users of our technology. And then, I don't want to say a life-changing sort of experience, but we were fortunate to be part of the Cogno project, which again was another EU project, this time in FP6. We worked with our colleagues from the VUMC in Amsterdam in the Netherlands. And they were the, if you remember back, one of the first slides I showed about the assessment of unmet needs of people with dementia and carers. And they conducted a huge amount of analysis of what types of needs and support would be required if we were to introduce some form of ICT or technology-based solution. So we proposed and we developed this, again, technology-based reminder solution for people with dementia to look at the 4 areas of providing support with daily activities, to provide support with communication, to provide support to increase or enhance feelings of safety, and also to provide some reminding support throughout the day. And across that, and this is why I said it was very changing to how we conducted our work, we looked at an iterative development cycle. we looked at a much more complex approach of how we would develop, how we would do small sort of bursts of development, engage with our stakeholders, and for the first time our work was really switched from being technically led to being clinically led. And I think as we move forward, and we've already heard it a number of times today, this is really the paradigm shift that we needed. And we see a lot of benefit, or we found a lot of benefit in our work taking this approach. So this was the strategy that we had proposed from the outset of how we would develop, or how we would address the challenge from a project point of view. We had ideas of what our vision should be for a solution. We had an appreciation of what was actually feasible from a technology perspective. We had a number of scenarios that we had to take into account from the clinical needs. And then we went into the cycle of 3 or 4 developments of producing, evaluating and engaging with our stakeholders and clinical partners in the project. And we produced 2 components really in the Cogno project. One was this touchscreen unit that we left in the person's house, and one was at the time it was a Windows mobile based solution which tried to replicate a lighter version or a more reduced version of what we had in this stationary component within the home environment. So I would say what we tried to do was put as much technology into the home, as much technology that we could, and consider what were the best components or what was the best impact through the evaluations. So I think we overloaded or we overcomplicated the process, but by doing that we had a good selection to identify what was the way through. And this one slide really doesn't do the project justice in terms of all of the evaluations that we conducted over a 3-year period over maybe 40 users in 3 different countries. But I wanted to highlight, and I was looking to see what was the most interesting thing that I could talk about today. And one of them was, in terms of the technology itself, was a focus on not only the person with dementia, but also the involvement of the caregiver in the process. The second point was better technology, so improved display of the information on our devices. I'll skip this one, and the third one was the ability to provide navigation support outside of the home environment. So all of this was leaning towards, don't focus on something inside the home which is stationary, but try and give something which is more pervasive and more dynamic for the user to engage with. So in the final report, I looked at the end of 3 years. I looked at what we wrote in our summary, and these 4, I think, quite seminal findings for us in this work. Number 1, we needed to make the technology more ubiquitous and not stationary within the environment. So that fits in very well with what we're talking about today from an mHealth perspective. The second thing, to make the solutions more everyday from a technology perspective. So we want to look at how we can leverage what's already there in the environment, rather than having to introduce a new form of technology or highly sensorize the environment. The third thing, to engage with all of the stakeholders in the design and evaluation, to be co-creators in the process. And the last point, and this becomes the interesting, or brings the computer science back in, from my perspective, back into the design. How can we make this personalised? How can we make it clever? How can we make it more adaptable to the scenario on a case-by-case basis? So just as we were finishing that, we really moved on, and I think in 2008, to the development of apps, or our journey towards the development of mHealth apps. And we had a very, very simple solution. We worked with a geriatrician from Belfast City Hospital. We had this vision that we should deliver reminders through a mobile phone, and that reminder would be a video of the caregiver or a family member delivering a message to say, Mom, it's 2 o'clock, take your medication. Mom, it's Thursday, don't forget you have a hairdresser appointment. And really that work has been the main thrust now of our group since 2008. And we've seen a number of research studies, we've seen a number of projects, a number of people involved, and outside you can see 2 or 3 of our projects related to this notion of video-based reminders through mobile phones. And that was our first mobile unit, and it was I think that was a Sony Ericsson K800. And what we did was we tied all of the buttons together at a firmware level, so no matter what the person pressed on the button, we just got a reminder that they'd engage with the phone. So we can have some idea, was somebody using the device, did they see the reminder and did they acknowledge? So really, really stripped away all of the challenges, all of the complexities behind the system. And we worked as well at how can we engage the carer, how can we allow them to set the reminders, record the videos, deploy those onto the mobile units. So this is a summary from a technology point of view. We started off with, as I said, Sony Ericsson handsets we're developing on Symbian. We moved to Windows Mobile, and just around here in the middle of 2011, we started for the first time in our group the development of Android for our solutions in this domain in healthcare. And really from there, all of our work has been really Android based ever since. And two of my colleagues are here today with me, and they can tell you as well about a lot of the work that we've been engaged in this area. So this is our technology journey, and here we had all these different types of evaluations, engagements, clinically driven evaluations of what we'd actually undertaken to try and understand how could we get to this point and offer a solution that was really going to provide some utility and would allow engagement with our target users. What we found then in our evaluations was were a lot of practical challenges. So we can talk about the underpinning theory, we can talk about multidisciplinary teams, we can talk about behaviour change, we can develop our app, and we can give it to our patient, and then they don't charge it. They don't use it, the device could be lost, we have no signal on the phone, we have usability issues. So a lot of practical challenges that existed, and we found this in our evaluations. So we found, I mean, these are just some examples, people who didn't engage with the technology or the app at all, people who set reminders and missed reminders. And our work has moved very much now towards, well, why does this actually happen? And is there anything that we can do to try and improve this type of problem? Can we increase the numbers of reminders that are actually acknowledged once we escalate them onto the platform? And just to finish off in terms of the journey that we've come through, we looked at, and that really comes from all of the evaluations that we undertook at this point. We looked at the different types of stakeholders that were involved in the design process, and we looked at what type of information we could glean from them, which point in the development cycle could we actually gather some information, could we engage with them, could we ask them for some support. And we produced, say internally for ourselves, but we did publish it, a recommendation of how we can engage with our stakeholders at different points in this sort of co-creative process. So if we wanted to have some evaluation and test and trials, and if we wanted to consider what is the utility of this technology, we have some notion now of who we should engage with, what sort of tools that we should use to gather the information, and how we can incorporate that back into the design of our solutions. So what are the lessons learned from all of this, and how are we using that moving forward? And I think we've learned so much from this journey that we've had, and we've really radically changed how we've approached this problem over the past 2 or 3 years. And I've put up here what were the lessons learned, or what were the areas really that we have to focus on. And this is biased, I would say, from a technology point of view, and in a way I'm holding my hands up to say yes, we were naive, and yes, maybe we didn't take all of these factors into consideration at the start. But if we run through this and maybe just very quickly look at each of these as we go around. So I've already mentioned everyday technology. So what we want to do, or what we find, if we can deliver our solution on top of the technology that's already there, and I think the mobile phone is a classic example, development of an app, use of digital radio, smart TVs, and not overcomplicate the environment of the user. What's our methodology from a development and evaluation point of view? Very, very important in terms of structuring that process and not be heavy in terms of the technology development and oversee the clinical evaluation. So those two go hand in hand. The role of all stakeholders. So we found very quickly, especially in this area of support for people with dementia, the need to take into account the aspirations of the caregiver. And longitudinal analysis, I think this for me is probably the key point. And Jane mentioned this as well this morning. We really are lacking a lot of evidence on a large scale over a long period of time. to show the evidence that these actually work, and without that it becomes very hard to try and encourage adoption within our healthcare systems. Data aggregation, there's a lot of information around the person, contextual information, and how can we bring that into the overall analysis or the support or the understanding of the healthcare condition of the person. Health economics, can we afford to introduce this? Will someone pay for it? How much does it cost? And technology adoption, and that's what I want to just finish off, which is where our work has focused in the last 2 years. How can we identify what are the correct people to use this technology, and how can we improve their adoption and their adherence to use the solutions that we've actually produced? So if I look back, and this was the sort of first slide that I said in 2004, our journey has been one from decision support systems to assistive technologies, and still trying to squeeze a little bit of computer science there. And now we appreciate we have to have long-term evaluations, we have to introduce a form of behaviour change, and we're talking now about big data and analytics with all of the information that we can gather. So our technical development has radically decreased if we think of our involvement in these projects and the amount of user input and evaluation. And I think that's a representation of cross or multidisciplinary work has actually increased. So we still have an involvement, I would say, from a technology point of view, but we're finding we're being led much more than leading the solutions that we're working or aspiring to actually deliver. The second point, as a technologist, it's always very dangerous. We want to push the cool stuff out. We want to have all of the new technology, the phones, the wearable tech, all of those sorts of gadgets. What we need to do is sit back and listen for user needs, listen what has to be developed, and there's much more impact than having a low-tech solution with high impact from a user's perspective. The methodology, there's a lot on this slide, but basically 2 points I think are really key. At this point, if we think of starting a new project today, we don't need to spend a long time gathering user requirements. There's clinical evidence already there, a huge amount of information has already been gathered. We can really shortcut this stage. And what we want to do in terms of the amount of effort is let the technology loose in the wild. So we talk about evaluations in the wild. If we have 3-4 people in a workshop and we're showing them exactly how to use the device, hold the device, oh no, don't touch that button, that doesn't, you don't want to do that. We need to just let all the solutions go and see what happens. And without this evidence in the wild over a long period of time, it's going to be a real challenge for us to try and get some impact or real evidence to show that these solutions work. And the final point in terms of the lessons or the appreciations that we have gained, the evaluation strategy is really, really important. So as I studied electronic engineering, nobody told me anything about how to design a questionnaire. I did a PhD in biomedical engineering. No one told me how I should structure, I should analyse, I should collect the information. We used to ask questions like, did you like this, yes or no? Then we came to write the summary of our paper and we said 3 people liked this. And, so really, if you haven't got a contact with a social scientist or somebody who can really give you support from an evaluation, I think that's something we are really lacking and is really important in your approach. So to look at it from the human factors perspective, that's for the user, did they like it? From a technology point of view, did it offer some advance in the state of the art? And this is important too from a business perspective. Is it viable? What are the health economics around what you've developed or what you're trying to introduce? So just to wind up on 4 or 5 slides very quickly about the work that we're involved in now. We went back and looked at all of the data. So we saw that we had 40 users had our system, and a certain percentage of them dropped out. And we thought, well, that's quite strange. Why is that actually happening? And we took 11 parameters that we had from those users, and we did a very simple regression model, and we were able to predict, with quite a high accuracy here of just under 83%, based on this information, who was going to adopt our technology and who was going to drop out. So what we're trying to do now is have a very simple screening test that at the point of prescribing your mHealth solution, we can ask 10 questions and we can give an idea of this person is going to adopt or they're not going to adopt the technology. And that has been a shift for us in our work, but it's a very, very interesting area, and we found very interesting results. So this is our new 2015 Reminding app, which I just wish we would have had a Android in 2004 whenever we started to do our development with the Medicaid project. And Philip Harton, my colleague, is in the back row. He's here today, so he probably can have a demo of this or speak to Philip about the development of Android apps. We partnered with 2 universities in Utah, Utah State University and the University of Utah. Very, very interesting clinical partners. One of them has this database, the CCSMA, and they profiled just over 6,000 people with dementia over a period of 15 years in Utah, and collected a lot of information and biannual assessments. And then we've linked this with the Utah Population Database, which is information of 7.3 million people in Utah State. And with our modest app, we've deployed this. We've been able to generate, or we've been able to analyse usage patterns. We've been able to analyse how many reminders were set, how many reminders were missed, what sort of days of the week this was used on. And we're in the process now of correlating this information that we can get from our app with the information that has been gathered from the cognitive assessments of the people in Utah with this large database that covers all of the different records of people in Utah. And this is really exciting for us in terms of how can we profile adopters and non-adopters of our technology, and how can we build models and understand who's going to use this in the future. And just to give you some ideas, again, we have a poster outside that we can talk to you about at the break if you're interested. So we contacted 347 participants and 140 refused. So that's really interesting. So maybe you just throw that data away and you look at the 30 who actually enrolled. But we're very interested in why are these people not engaging, why are they not interested in this study, and how can we use that information to help us build our systems and try and identify who's going to use or who's going to adopt the solutions, and how can we improve their engagement over time. So far we've had 6,500 reminders across these users that we're working with in Utah. We just finished in February of this year, and we're now in the process of correlating this information, the usage patterns, with the information from the CCSMA and the Utah Population Database. So maybe if Jane hosts a conference next year, we can come along and tell you what we actually found and what sense we made out of this. This is maybe quite scary, but it's interesting to look at these figures. So of the reminders that were set, only 30% of them were acknowledged. 70% of them were missed, and of the missed reminders, 15% of those were because the phone was turned off. So if we look at this, if the phone was turned on, would that have increased the number of reminders, for example? And they're the practical issues, the practical challenges that we're trying to look at addressing to see can we offer some marginal gain in the performance or the usage of our system. Engagement over time, not to go into this in too much detail, this is the average number of reminders set over a 44-week period, and you can see we're decreasing here from the start down to maybe 1 or 2 reminders over time. So the usage does sort of peter off. We can see the percentage of the number of reminders acknowledged also decreases over time. So why did that happen? What can we do at these points in the process, or what can we do from an e-engagement point of view to keep people engaged and keep them using these solutions, or these mHealth solutions that we're talking about. So just to conclude, I think I'm running out of time. We heard a little bit about the strategy in Ireland for healthcare and health and technologies. This was a report that was produced in February in Northern Ireland with an assessment of the life and health sciences produced by the Matrix panel. And I've taken the liberty to take the graph or the vision from this, from the executive summary from the report. And basically here, if you read the report, it says connected living, which I think covers everything we're talking about today. Technology and healthcare, mHealth, is the opportunity that we're seeing in Northern Ireland of, and this report is given as a recommendation to government of how they should redirect their their budgets and their strategies over a 5-year period. So that was very positive and very encouraging to see that in terms of the area that we're working in, and we heard it this morning for Ireland and in Northern Ireland is being really highlighted as one of the key opportunities to address the societal health challenges that we have. The second thing, our group has really gone app mad. Everything we have at the minute has an app associated with it, Android associated with it. These are some of the projects we're involved in. We've got posters outside. This one is a rehabilitation app, post ankle sprain. This uses NFC tags to give instructional videos. This helps with directions throughout Europe. Taught is what I've talked about. It's a reminding app or technology adoption and usability modules. And this is a project that we're working with a university in Korea where we're trying to create a large annotated data set through just prompted at different times throughout the day, what activity did you just engage with? And then we label the accelerometry data on the phone and we store it on the cloud. So we have posters for those outside if you're interested to come and talk to us after this session or at lunchtime. And this, I'll just finish on this slide. I mentioned that we had a collaboration with our colleagues in Utah. And it's the development of technology adoption models. And at one of the lunch breaks we had with our clinical colleagues, they said, we want to ask a questionnaire of how people might change their lifestyle if we gave information of the effects that lifestyle had on prevention of Alzheimer's disease. And I said, I know a guy, he's one of our PhD students, very good, he'll do that maybe 2 or 3 days. That was maybe 18 months ago and we're still working on the app for them. But we have conducted an RCT over a period of 6 months with 146 individuals in Utah. And we looked at this notion of lifestyle change and the effect that lifestyle change had on the prevention of Alzheimer's disease. And rather than, I suppose, everything up until this point I've talked about, let's offer some support for people with Alzheimer's and people with or their carers. Now this work is moving towards, well, can we change the lifestyle that has an effect on the onset of Alzheimer's disease, and can we avoid that, or can we do something to prevent? And we found already some very, very interesting results. We have a huge amount of results. Philip is here today and he can talk you through all of these at the poster, but we've seen from this RCT behaviour change through engagement with our app, and we can show a demo of this as well if you're interested to hear more about it at the break. So just to summarise all of that, I feel I've rambled quite a lot there in the past 40 minutes. What's the summary? I've put some points here, but I think we need to work harder. The opportunity is there. Multidisciplinary teams, I think, are key. If we look at what government is saying, if we look at what Europe's saying, or broader than that, this is a very, very topical opportunity, and I think the time is really now for us to seize the opportunity and show all of the good work that we're doing and try and disseminate it as widely as we can. So I'll maybe leave it there, and I'll be here around, I think Jane's going to nab here for something, no doubt. So thanks very much for listening.